Welcome, everyone. On behalf of the Centers for Medicare and Medicaid Services Division of Tribal Affairs, I would like to welcome everyone to an All Tribes Consultation webinar. My name is Nicole Pino, and I work for Kaufman and Associates. I will be your moderator today. Today's webinar is titled Traditional Healthcare Practices in Section 1115 Demonstrations. Please note this webinar series is supported by a contract awarded by the Centers for Medicare and Medicaid Services. And at this time, I will turn it over to Beverly Lofton. Thank you.
Thank you so much, Nicole. Good afternoon, everyone. I am Beverly Lofton. I'm a Senior Policy Advisor in the Division of Tribal Affairs, and welcome. I'm Beverly Lofton, and I am a Senior Policy Advisor in the Division of Tribal Affairs. And today is a consultation webinar. During today's webinar, CMS will provide an overview of CMS's approval of 4 state Section 1115 demonstration amendments that allow for the first time ever, the Medicaid and CHIP programs coverage of traditional healthcare practices provided by Indian Health Services, which is IHS facilities, tribal facilities, and urban Indian organizations. Just to note, any cleared materials related to this presentation can be downloaded from our spotlight page of the CMS American Indian and Alaska Native Outreach and Education website, and that website can be found at go.cms.gov/AIAN. The web link will be added to our chat. So we are pleased today to be joined on this webinar by Group Director J.C. Cooper and her staff from the CMS State Demonstrations Group. So now I will turn the webinar over to J.C. to begin the webinar. Thank you.
Hello. Thank you so much for joining us today so that CMCS can provide you an update on traditional healthcare practices. Oh, let me just make sure. Can you hear me? I just got a chat saying cannot hear. After over a decade of work, to be honest with you, we're really happy to join you today to provide this update. The request came in originally from Arizona to move forward with the approval in an 1115 demonstration for traditional healthcare practices. And then multiple states came after that with a similar ask. And really here, focusing on, the goals of this demonstration is really to ensure that we have wide use of traditional healthcare practices across tribal nations and over generations, and that those can be incorporated into how we close disparities or gaps of disparities in our Medicaid program for American Indians and Alaska Natives. So we're really happy to lift up and recognize and support Indigenous knowledge and improve access to healthcare services with this demonstration. You have been so thoughtful over many years, and more recently in the last year, where we've done extensive consultation with tribes to shape the framework that we will be presenting to you all today in regards to how we were able to achieve approval of the 1115 demonstrations. So we will, we have recently announced approvals. So happy to finally say we have announced approvals in Arizona, California, New Mexico, and Oregon. And while building this demonstration, we really built it on a framework. So key components across who's eligible for the demonstration, the providers who are eligible, how we are approaching, and we streamlined that across all 4 of the demonstrations that we approved. And we would be taking that framework if other states were interested in coming in for an 1115 demonstration within this space. Within this framework, there are things that we are set on. They are required components of the demonstration. And then there are places where states have the flexibility to make decisions for their state, their delivery system. And as we walk through the framework for you today on this call, we will highlight the areas where there's flexibility, for example, where states can choose certain components of the demonstration. And so next slide. Myself, Kate, and Kelsey are very excited to walk through the framework. So these are the main components that we will walk through today. We'll walk through who's eligible for these demonstrations. How are we looking at the federal medical assistance percentage, or what's known as FMAP, across the various components? We'll be looking at what are the types of services that can be provided, traditional healthcare practice services, and by who, which providers are eligible to provide these services in the demonstrations, as well as other support that CMCS is offering states to be successful in the implementation if they choose to have implementation expenditures, and then how we plan to evaluate this demonstration and any post-approval actions that states and CMCS will be taking over the coming months and years. So I'm really excited to turn it over now to Kate, who will continue to walk through our various framework components with you all.
First, we want to go over eligible beneficiaries. So who is able to receive these traditional healthcare practices? In our demonstrations that we've approved, eligible beneficiaries include any Medicaid beneficiary who is able to receive services delivered by or through an IHS or tribal facility. We are also allowing states to include urban Indian organization facilities in their approval. And so for states that have included urban Indian organizations, Medicaid beneficiaries are also able to receive services by or through a UIO. But there are some non-American Indian or Alaska Native individuals who are able to receive services delivered by these facilities, and they are also included in this demonstration. A state can also choose to include CHIP beneficiaries, and if they choose to do so, those beneficiaries are also able to receive services delivered by IHS, tribal, or UIO facilities. We are also open to reviewing applications from states that apply additional beneficiary criteria to eligible individuals or choose to phase in certain populations during the demonstration period, which is usually 5 years. For example, California is a state that will be phasing in populations and additional beneficiary criteria, and we will discuss each state's application and approval later on in this presentation. We wanted to take a moment here to discuss how the state and the federal government will be paying for these services. As most folks are probably aware, American Indians and Alaska Native individuals who receive care through either an IHS or a tribal facility will be eligible for 100% federal medical assistance percentage, or FMAP. The federal government will pay 100% of those costs. Again, those are Medicaid beneficiaries who are American Indian or Alaska Native and who are eligible to receive services by or through an IHS or a tribal facility. For all other individuals, states will receive the applicable state service match, or the regular state FMAP. So those include services that are delivered to Medicaid beneficiaries at urban Indian organizations, services that are delivered to CHIP beneficiaries at any of these facilities, and services who are delivered by or through these qualifying facilities to Medicaid beneficiaries who are not American Indian or Alaska Native. We will cover through these demonstrations any traditional healthcare practice that is being delivered by or through IHS, tribal, or UIO facilities if a state is including or UIO facilities. This means that any practices that the facility is currently providing, or once the state comes online and is able to provide new practices due to this coverage, these new practices would also be covered. So we are not in any way determining what types of services or requiring the state to provide a list of the types of services facilities are allowed to provide under this demonstration. We know that services are already being provided by these facilities, and we are leaving it up to the facilities who are the experts in delivering these practices. CMS will also not require any type of certifications or licensure for providers or practitioner of these services. We understand that facilities are the best places to make a determination of who is eligible to provide these services. We are requiring, however, that providers or practitioners of traditional healthcare practices must be either employed or contracted with the IHS, tribal, or urban Indian organization facility. Additionally, each facility is responsible for determining that their providers and practitioners of traditional healthcare practices are qualified to provide these practices to the patients of the qualifying facility, and they have the necessary experience and the appropriate training. The facility will be the one determining what those experiences and trainings are. The qualifying facility is also expected to establish methods for determining who is and is not qualified, and be able to provide that documentation to the state upon request. Facilities are also expected to bill Medicaid or CHIP, if the state chooses, for these practices only furnished by employees or contractors. And lastly, as I stated earlier, the state must make all of these documents and activities available if the state requests. I will now turn it over to Kelsey. Thank you.
Thank you, Kate. Hello, everybody. I'm going to be talking about implementation funding. CMS would consider approving administrative implementation funding to allow states to support the providers, the qualifying facilities of those delivering traditional healthcare practices. As Kate said, although that we know practices may already be offered and delivered by these facilities, the facilities are not currently being reimbursed for paid for these practices by Medicaid or CHIP. They may not necessarily have all of the infrastructure set up in order to roll out these practices. So that would include any type of coding or billing, tracking for these services, payment systems in place. The implementation administrative funding can also aid in any type of staff training and recruitment of practitioners, as well as outreach around the available practices, education around those practices, and community engagement in delivering those practices. CMS will be working with every state that we approve a traditional healthcare practices demonstration for to create a process to monitor and evaluate the approved demonstration components. And this is done with every Section 1115 demonstration approval. The evaluations for traditional healthcare practices demonstrations are expected to assess beneficiary awareness and understanding of the traditional healthcare practices, access to and cost of those practices, the general utilization of the practices, the quality and experience of care for each of the beneficiaries, and then any physical and behavioral health outcomes as a result of utilizing traditional healthcare practices. Now that we've approved the 4 states, each of these states, in consultation with their tribes, is working on a timeline and a plan for implementing the approval. With this post-approval process, each state must provide some type of attestation providing adequate access to secular alternatives to traditional healthcare practices. And for any condition addressed through the use of traditional healthcare practices, the state must ensure that a beneficiary has a genuine independent choice to use any other Medicaid or CHIP covered services if that beneficiary so chooses. The state must also attest to ensuring that traditional healthcare practices may not be used to reduce, discourage, or jeopardize a beneficiary's ability to access other Medicaid or CHIP covered services or settings that are already provided by the state. And the FFP, or the payment for these services to the state, is tied to the submission of this attestation. So in summary, this all means that traditional healthcare practices will be provided in addition to any other Medicaid or CHIP covered services, and traditional healthcare practices would be used as part of multiple treatment options that a beneficiary has when choosing their care. Each state, as is already required, must notify beneficiaries of their rights to file grievances, complaints, and appeals related to this attestation and take any needed actions or monitoring that's consistent with our federal laws and regulations regarding grievances, complaints, and appeals. As JC and Kate mentioned, we currently have some allowable variations or flexibilities when determining what CMS would approve for traditional healthcare practices demonstrations. Our expedited framework approvals allowed for certain specific variations, including the inclusion of urban Indian organization facilities, the inclusion of separate CHIP beneficiaries, the inclusion of administrative implementation expenditures, and then also CMS would also consider states' proposals to apply additional beneficiary qualifying criteria or to phase in the populations. An example of this is what was approved in California, which Kate will discuss more on the next slide, which is to initially target the traditional healthcare practices to the drug Medi-Cal organized delivery system, which is a SUD, substance use disorder delivery system. And the demonstration approval also provides authority for the state to expand the program over the course of the demonstration period without coming into CMS to seek an amendment. If states come in with a request in the future for additional variations or flexibilities outside of those listed here, CMS would then follow the usual non-expedited review and approval process for those variations. And I will pass it to Kate.
Thanks, Kelsey. As you all are aware, we approved 4 Section 1115 state demonstrations, and they are all a little different, but within our proposed or our framework that we have discussed here. I want to draw your attention to a few differences between each of the 4 states. In Arizona, the state we approved in Arizona participating facilities of IHS and tribal facilities. While urban Indian organizations are not included, care coordination agreements with UIOs are available in Arizona. In California, initially, the state will be expanding traditional healthcare practices only to Medicaid and CHIP beneficiaries who are part of the substance use disorder program called the Drug Medi-Cal Organized Delivery System. For those individuals who receive services through the DMC ODS, they will be able to receive any type of traditional healthcare practice through a IHS, tribal, or UIO facility. We also approved at the same time authority for California to expand the population to all Medicaid and CHIP beneficiaries, and the state will announce if and when they choose to do that without needing to get additional CMS approval. New Mexico and Oregon both utilize the full extent of our framework. They are providing services to Medicaid beneficiaries at IHS, tribal, and urban Indian organization facilities. Oregon is also including their separate CHIP program and CHIP beneficiaries as well. And both of these 2 states also requested and were approved to receive a set amount of implementation expenditure funds in order to support their implementation of this traditional healthcare practice coverage. We will now receive any questions and feedback on this framework and our approved demonstrations. You will be able to access these slides online, and as you can see here, they have links to the CMS press release that was released a few weeks back when we approved these demonstrations. It also links to the Dear Tribal Leader letter from the CMS administrator about this approval. And it links to all 4 state demonstration approval letters to explain in more detail what we approved and the terms and conditions each state has to abide by in order to provide these practices. We will now turn it over to questions. Thank you.
Thank you, Kate. Yes, this is our time for questions. I will go ahead and kick it off to the Q&A box now. We did have a question come in. I know the CMS prioritizes these 4 applications. Will TIM 1115 waivers be prioritized moving forward? I imagine many states are thinking about how to move their own 1115 TIM applications forward.
We're assuming TIM means the traditional healthcare practices or demonstrations that requests that come in that are similar to this in nature. If that is correct, then we would say we would have a framework now, which would allow for us to move these through an expedited process, which is would be easy as long as the state and tribes are requesting things within our approved framework. If they ask for something that was substantially different or needed changes to that framework, we would have to go through a clearance process. So if it aligns with the framework we just walked through, it does allow for us to move those through on a faster pace. However, we still have federal regulations that require certain actions and timelines take place, and so we would still need to meet any of those. If TIM means something else, please put that in the chat so we can address your question more particular.
Thank you, JC. Next question came in from Martin. Does this include non-IHS household members, for instance, as non-American Indian Alaska Native beneficiaries to receive services?
Yes. So if an individual is eligible to receive services by an IHS or tribal facility, then they are also eligible to receive these traditional healthcare practices.
Thank you, Kate. Next question. Are Native nonprofit organizations who are independent of their host tribe but offer traditional healing services able to provide to be Medicaid providers or added to the list of service providers?
I can take this one. So the participating facilities who are eligible to receive payment for traditional healthcare practices include IHS and Tribal 638 facilities, in addition to urban Indian organizations. So there are existing federal statutes and requirements around the types of facilities that qualify for IHS, Tribal 638, and UIO facilities. And the facility in question would have to meet those criteria in order to be eligible to receive payment for traditional healthcare practices.
Thank you, Kelsey. Next question is from Elena. We are a nonprofit organization in California. Would we be considered an urban Indian organization?
I would refer you to Kelsey's response to the previous question. You would need to determine if your nonprofit organization meets the federal requirements of an urban Indian organization. And if you do, then you would be considered part of this demonstration.
Thank you, Kate. Next question is from Perdita. How many clinics actually have traditional healers on staff? I'm especially interested in New Mexico data, but happy to hear about other states as well.
I'd refer you to your state Medicaid agency. They might be able to answer this question. We do know and we hope that by approving coverage of traditional healthcare practices, it might be able to increase the number of facilities who are able to hire traditional healthcare practitioners, but any count of practitioners or providers would need to come from the state.
Thank you, Kate. Moving on to the next question. For Michelle, how do we find out if we qualify in California? We aren't sure if we are in the DMC, ODS. Who should we talk to?
I would also recommend reaching out to the California State Medicaid Agency, and they would be able to let you know.
Perfect. Thank you, Kate. Next question is from Yvonne. Did I understand that traditional healing services provided through an urban Indian organization will not be eligible for the 100% FMAP?
That is correct. Federal statute does not permit 100% FMAP for urban Indian organizations. Federal statute only allows 100% FMAP for IHS or tribal facilities.
I will add on there that if the services are provided through an urban Indian organization through a care coordination agreement with an IHS or tribal facility, then they may be eligible for 100% FMAP.
Perfect. And we had a clarifying acronym for TIM, which stands for Traditional Indian Medicine. So thank you for answering that question. Next question would come from Jessica. Will billing guidelines and reimbursement rates be published? And would the MOA rate apply?
Yes, so you should refer to your state Medicaid agency. They will be publishing all their rates as they do for any other service.
Question is from Jessica. In California, drug Medi-Cal is by county. If the county is not participating, does this affect our beneficiaries?
Yes, so initially in California, only those beneficiaries in those counties that are part of the California Drug Medi-Cal organized delivery system will be able to receive traditional healthcare practices. But again, you should reach out to the California State Medicaid Agency if you have additional questions on the DMC ODS.
Thank you. Next question is from Andrew. How does CMS plan to develop their fee schedule or determine whether charges are within reason? Will traditional healers services be reimbursed at the all-inclusive rate?
Yes, we have given states the option to use the all-inclusive rate or create a new rate methodology. Currently, we know that most states are using the AIR in some situations, and other states like California are creating or are using other rate methodologies they have already created, or states have the option to create a new rate methodology. And you should reach out to your state Medicaid agency with further questions on that.
Next question will be from Dr. Jessica. Is there funding to pilot any certifications state tribal colleges?
If I understand your question correctly, and please add in if you want to correct my response, but we are only covering services provided at IHS, tribal, or urban Indian organization facilities. We are, as CMS, not requiring providers to have any type of certification or licensure. The facilities themselves will determine what the appropriate qualifications are for their own providers or practitioners.
Perfect, thank you. Next question is from Darla. It is my understanding that most IHS facilities in California are not DMC ODS facilities, so this requirement is a barrier to providing traditional health services to our patients.
The nuances of California's delivery system, we would not be able to provide technical responses to, so we strongly recommend that you reach out to California to get any clarification in regards to who is included in their DMC ODS network.
Next question is from David. Is there a list of states that have applied for the 1115 waiver, and is Wisconsin one of these states?
You can find the list of states that have applied for Section 1115 demonstrations on Medicaid.gov, and we can put the exact link in the chat. Wisconsin is not on that list right now, but we are always happy to provide technical assistance to any state that wants to request this coverage.
Perfect. Next question is from Delphine. Will states who did not apply for implementation expenditures get another opportunity to apply for funds? If so, when?
Yeah.
So states have to use, Yep. So states have to apply through the regular state demonstration or the regular 1115 demonstration process. So if a state chose to come back in and request additional or new implementation funds, CMS would consider that request and make a determination. But in order to get any sort of approval, states have to submit an official Section 1115 demonstration amendment or extension request.
Perfect, thank you. Next question is pertaining to how to find the PowerPoint. I did want to take the opportunity to also remind attendees that today's webinar was being recorded, and that the recording and slides will be made available online at cms.gov. And again, I do see that Beverly had typed in the address, so if you need to look for it, you can look for her chat. I'll move on to the next question. Praditha, might state Medicaid agencies that are part of this traditional health demonstrations project be doing webinars?
You would have to reach out to your state and inquire if they are or not.
Thank you. Next question from Lena. How should we go about requesting TA, technical assistant from CMS on our application?
The way Section 1115 demonstrations work is that we work directly with the state. And so I'd recommend reaching out to your state Medicaid agency, as they would be the ones who would be working with us directly on the application.
Thank you. And next question from Ashley. Can you remind me, what is CMS's definition of traditional traditional healing services?
We know that there are wide varieties of answers to this question. Everyone defines it differently, and CMS has not made a determination of what we consider to be traditional healthcare practices. You can see in the approval letters, we use the WHO definition of an example of what traditional healthcare practices could include, but we understand that every tribe, every state, sees it differently and defines it differently. And so we would refer you to IHS or to your state to determine what would qualify as a traditional healthcare practice.
Perfect, thank you. Next question is from Redbox. Are you able to bill multiple traditional Indian medicine services just as you can with regular services?
Yes, so this would be part of the maximum encounter rate in each state. And so just as you were able to have multiple physical health or mental health, behavioral health visits, traditional healthcare practices would count as another one of those encounter rates up to the maximum state allowed limit.
Thank you. Next question from Lynn. Are Indigenous doulas, Indigenous breastfeeding counselors being considered as traditional healing services?
I'll take this one. Each qualifying facility is able to determine the traditional healthcare practices and the provider qualifications for what falls under the umbrella of traditional healthcare practices. So we would defer to the qualifying facility, being the IHS, tribal, or UIO facility, to make the determination around what practices and providers would be included here.
Great, thank you. Next question is from Perdita. Can you give us contact information in New Mexico for Medicaid?
You can go to the New Mexico Healthcare Authority website and find a contact for someone who can help you with this question.
Thank you. Next question again is from Perdita, or from Jody, I apologize. May I please get Kelsey Smith's email? I'd like to send a follow-up question. Sure.
I'd be happy to answer a question here, but I think we're also going to offer up the Division of Tribal Affairs email box to answer any questions after this presentation. But Jody, please feel free to also include your question here. I'd be happy to answer it today.
Thank you, Kelsey. Next question is from Mrs. Lightfield. How will the approval of these traditional healthcare practices affect future decisions about the Four Walls policy?
This approval does not impact any regulation or other decisions on Four Walls. It would fit in if a decision is determined, but does not in and of itself make any changes to the Four Walls policy.
Okay, thank you. It looks like there are no more questions in the Q&A box. I do want to remind everyone that you can type in your question in the Q&A box located at the bottom of your screen, or you can also use the raise hand icon and we can unmute you and you can ask your question directly.
And just to jump in, thank you. Just to jump in, our tribal affairs email box or mailbox is found at tribalaffairs@cms.hhs.gov. And I'll repeat that later on today.
Another question came in from Dr. Jessica. Some of these practices involve significant setup. Is that time covered as part of the billing practices?
So, however, your state Medicaid agency bills and includes setup or other costs in their reimbursement rate is how traditional healthcare practices would be billed. And so again, I would recommend reaching out to your state Medicaid agency to determine what is part of their reimbursement rate.
Question is from Lena. If we use the framework laid out by CMS, how long should we expect the approval to take?
We unfortunately can't give any definitive timeline. I will say that now that we have a framework, that hopefully makes things easier moving forward, but every state would have to come into CMS with their Section 1115 demonstration amendment, and we would then make a determination and work with that state towards approval.
Thank you. Next question is from Jody. Kelsey, you said that urban Indian organizations could have a care coordination agreement with a tribe and then access the full FMAP reimbursement. Is that also accurate for other medical services?
Yes, so there is published guidance from CMS on Medicaid.gov and a state health official letter that specifically talks about care coordination agreements and when services provided by UIOs through care coordination agreements are eligible for 100% FMAP. And there's additional guidance that's published by the Indian Health Service as well with example care coordination agreements. So I would encourage you to check out the resources online for more information.
Thank you. Next question is for Merlin. Do you know why UIO were excluded in the Arizona program?
The CMS framework allowed states to choose whether or not to include UIOs. Part of that decision comes down to the FMAP for UIOs, which is at the state match or a state service match. And so states have to be able to provide that part of the reimbursement. But every state had the opportunity to make the decision based on their priorities and their funding availability of whether or not to include UIOs. But I would again emphasize that care coordination agreements are a possible path for UIOs to be part of the Arizona coverage of traditional healthcare practices.
Thank you. Next question came in from Kevin. The waiver mentions a requirement for the state to attest that secular, for instance, non-religious or spiritual forms of traditional practices are available. Who from the state makes that determination what is secular versus religious spiritual? And how is the determination made?
I'll hop in on this one. The state has a number of Medicaid services that are approved in their state plan or through other 1915C or 1915B waivers with CMS. They may also have other demonstration specific benefits that they offer to their Medicaid agencies. That's what we're referencing when we say that they need to have a comprehensive list of other services available. The state would be the one responsible, the state Medicaid agency would be the one responsible for doing that assessment and attesting that they have adequate access to all of those various other secular options for the beneficiaries in that state. The idea here is just to ensure that these are services in addition to what would otherwise be made available to them in their state. And not to be used to say if someone is receiving traditional healthcare practices they could not have otherwise access to, as an example, behavioral health, mental health, or substance use disorder services, but ensuring that all access to services are available for beneficiaries in the state in addition to traditional healthcare practices being available.
Thank you, Tracy. Next question comes in from Charlene. Will CMS also do a rating on traditional health care as they do for Medicare, Medicaid by state?
I'll hop in here. So not exactly. So we will be required to, which is required in federal law, to do an evaluation of the 1115 demonstrations. And Kate and Kelty walked through some of those pieces previously on the presentation. So each 1115 for each state will have a separate evaluation. They also provide various monitoring reports to us on a regular basis. So we know the utilization, the number of providers, how things are going, and we can help troubleshoot. But there's not an official rating system on traditional healthcare practices like you see in Medicare.
Thank you. The next few items on here is not a specific question, but maybe for individuals who are based out in New Mexico. Perdita did provide contact information for Shelley Begay, who is the Native American liaison, works with HSD and helps monitor state tribal issues for the department, assist in formalizing the department's government-to-government relations, and works with the Department of Indian Affairs. So again, you can find the contact information in the Q&A box under Answered. I will go ahead and move on to the next question. Will be coming from Virginia. Does the state have to submit an amended waiver to expand their current approved waiver to match another state's waiver? For example, if California wants to remove the requirement to be in the DMC ODS and the limitation to SUD care, does that state have to submit an amendment? And can we assume any amendments that mirror the other approved states would move more quickly?
Yeah, thanks for that question. And I have a two-part answer. For California specifically, CMS gave authority for the state to cover beyond the DMC ODS to all eligible Medicaid and CHIP beneficiaries. So while California is beginning with just the DMC ODS, you do not have to come into CMS for any additional approval in order to expand to any additional group or population. They just have to give CMS notice and provide that notice to the state. But generally, states, if they want to amend their demonstration, would have to come in for an amendment that CMS would then approve. And while, again, we can't definitively say how long an approval might take, we do hope that any state that would come in within our framework of traditional healthcare practices would have an easier time getting approved, since we now have this framework for approval.
Thank you. Next question is from Red Fox. Are there IDC codes for traditional Indian medicine services? And how will health information management coding correlate with billing?
I refer your questions to the state Medicaid agency. I would say that there is a HCPCS code, a Healthcare Common Procedure Coding System code for traditional medicine that facilities can use. But any other additional billing or coding questions, I would refer to the Medicaid agency.
Perfect, thank you. Again, another question from Virginia. To be granular, does that also include beyond SUD?
Yes, so in California, we have provided authority for the state to cover up to all Medicaid and CHIP individuals who are eligible or able to receive services by or through an IHS, tribal, or urban Indian organization facility. If the state wants to go to anything between where they are right now and that full population that I mentioned, they can move in increments or in steps and not require additional CMS approval. So if they want to go slightly beyond their DMC ODS and then again slightly, that would not require approval. However, I do want to point out that if the state were ever to want to sort of decrease services or population, any sort of negative or contracting coverage of populations or services would require CMS approval. So the state can only increase, it cannot decrease without additional approval.
Thank you. Next question is from Joshua. He states, Kelsey, you noted that approved facilities have some discretion in defining their services. Does this latitude extend to group encounters? Specifically, would traditional healing conducted in a group setting at a facility level still qualify for the all-inclusive rate?
Yeah, thanks for that question. So just a broad note, the Section 1115 demonstrations that we approve don't in any way modify the existing rules around what types of services or group services or individual services qualify for the all-inclusive rate. And so if today in the state group settings qualify at a facility level for the all-inclusive rate, then traditional healthcare practices would fall under that umbrella. Just the broader note that our demonstration approvals don't change those existing rules.
Thank you, Kelsey. Next question is from Shahari. Is traditional healing coverage available under a state plan in addition to the 1115 managed care demonstrations?
No, right? Oh, Kelsey, yes, I see. No, traditional healthcare practices are not available under the state plan right now. Traditional healthcare practices and the Section 1115 demonstration are used to provide coverage for experimental or pilot coverage. And so right now, the answer is no to that. And just to be very clear, coverage for traditional healthcare practices is not specifically under a managed care demonstration. States can choose whether and how to provide these services within the statutory requirements that tribal members can't be, required to enroll in a managed care plan. But within those requirements, there is not a specific 1115 managed care demonstration.
Thank you. Next question is from Tina. Will healthcare practices include traditional medicine?
Yes, whatever practices, medicine, or other services or practices that the IHS tribal or urban Indian organization facility is providing as traditional healthcare practices will be coverable under this demonstration.
Thank you. At this time, there are no additional questions in the Q&A box. We do have a couple of minutes left. So I just want to remind everyone, if you do have a question, please leave your questions in the Q&A box and we'll address them, or you can also use the raise hand icon. Next question is from Hom. Is there any data or research on traditional healing and medicine and dementia care practices in tribal communities and the role of healthcare providers?
That's a great question. I would refer you to your state Medicaid agency or other research entities that might be able to provide you additional information. You can also see some links in our approval letters for these demonstrations, linking some quantitative and qualitative studies CMS discovered as we were working on this approval. But any additional data or research, I would refer you to your Medicaid agency.
Next question is from Roland. Will all these questions and answers be available? And again, I do want to remind this webinar is recorded and will be posted online at cms.gov. Beverly, is there anything that you'd like to add?
You answered that question. So we will be posting this webinar on our spotlight page, and that was on the site that I gave earlier, and I'll repeat that over when we close out today. But we will be posting this webinar, so you'll have all the Q's and A's that were framed throughout the webinar.
Thank you, Beverly. Next question from Dustin. Where would you find how Native tribal nonprofits apply to be eligible providers?
You can reach out to your state Medicaid agency and they can provide you additional guidance.
Thank you. And next question is from Tina. Will traditional providers need to be enrolled with their state Medicaid program to get reimbursed?
Yes, part of our requirements for practitioners and providers who provide traditional healthcare practices is that they are enrolled in Medicaid and CHIP if their state is including CHIP in order to get coverage and reimbursement.
Thank you. And I'll leave this open for another minute or two. Okay, got a couple more coming in. Lena, would they also need an NPI then?
So the provider or practitioner themselves would be employed by or contracted with an IHS tribal or UIO facility, and those facilities should have the provider numbers necessary in order to be eligible for reimbursement.
Next question from Shayna. Will you have any additional follow-up meetings regarding this subject?
For those individuals who are part of the CMS Tribal Technical Advisory Group, we will be presenting this as well, a very similar presentation to the CMS TTAG. And any additional questions or comments, I would refer you to your state Medicaid agency, who will be providing, I'm sure, additional guidance and technical assistance to facilities on how to operationalize this.
Thank you. A couple more that came in from Lynn. What are the requirements for traditional practitioners to become enrolled in the state Medicaid program to get reimbursement?
I know I'm a broken record at this point, but I refer you to the state Medicaid agency. They're really the experts in all types of enrollment questions for providers and any other questions providers may have. So they would be able to answer how you enroll as a provider.
Yeah. And just a quick comment from Roland. Thank you for the presentation. That should wrap up the Q&A section. I'll go ahead. If there are no more questions, I would like to send it back to Beverly Lofton for closing remarks.
Thank you so much. Thanks everyone for presenting, Kelsey and JC and Kate. Thanks so much for that great presentation. Everyone is really excited about these new services and new coverages and opportunity for coverages. So please make sure you stay tuned for additional information. Again, thank you for your participation. I want to remind you And as always, you can submit any questions or inquiries to the CMS Division of Tribal Affairs. That mailbox is again at tribalaffairs@cms.hhs.gov. And allow us some time to have the presentation available, because it will not be available right away. So that the slides or the webinar will not be available right away. So allow a few weeks, or hopefully within a week or two. And then we will also again post the slides to the webinar as well. So those will be two different materials that will be posted. So look forward to the slides more recent. So that should happen within the next few days. We're just waiting on clearances. I think we have another question. Oh, we just have a thank you. Thank you. All righty. So with that said, we will end today's webinar. Thank you so much.